We'll have a panel discussion on it, and I would like all you students also to equally contribute with your suggestions, because on one side we have our very eminent panel who are experienced teachers who will be adding their own perspective to it, and we would like to hear from the students as well. So I would like to invite Professor Suresh Gupta, who is head of the department ophthalmology at GMCH. So please come on the dais. We would like to have Dr. Neil. That it's not stirring up a hornet's nest. It's a very healthy discussion, and let's just put in our ideas and see if we can do something about it. But before I start, I would like to pay tribute to these doyens of ophthalmology. To your left, we have Dr. S.S. Badrinath, who was the founding chairperson of Shankar Nitrale Group of Hospitals, Chennai. And then we have Dr. Ranveer Thomas, who was the chief at CMC Vellore and ultimately went to Australia. Those who have been trained by these two people have now become masters of ophthalmology themselves, and unfortunately this year we lost both of these eminent ophthalmologists. And when we talk of student-teacher relationships, the relationships that people formed with such eminent teachers cannot be forgotten. So, very warm tribute to both the doyens. So with this, we go on to our first aspect of ophthalmology training, and that is curriculum. Now, Professor Suresh, myself, Dr. Tanu, we all have trained at different time points with a gap of at least 10 years between our trainings. But we had a very common curriculum which was run by NCI, and I think fairly we all have turned out okay. So do you think that there is a need to change the curriculum now, because things are changing rapidly and the generation gap is reducing at a much faster pace as it used to be? This relates to our value system as well as to the techniques and technologies that are available. Uh, First of all, I would like to ask Professor Suresh, since this wonderful idea was his, to have a healthy discussion on this topic. So, do you think we need to change?
I think change is life. So we have to keep evolving with time. So everything basically has to be dynamic. But at the same time, as Parul highlighted, the top people, top medical people in the country, if we go to like West US or Europe or anywhere out of the country, the doctors trained in India, they are doing excellent job. So rather people choose Indian doctors over other doctors for their treatment in West also. So this means, the current generation of top leaders in medicine, including ophthalmology, they have been trained in old traditional systems. So whatever curriculum was there and whatever ways of teaching were prevalent at that time, so they have come out best in their fields. So this means no system is perfect. You can have best people out of any curriculum or any system of teaching and training. At the same time, I would like to highlight that currently National Medical Commission has basically devised competence-based curriculum. So in this curriculum, we have to train both MBBS or undergraduates as well as postgraduate in various competencies. And then these competencies have to be
like a wife from a different caste. And the moment they go into super specialization, he or she is treated like a wife from a different caste who has delivered a girl child. So something is wrong somewhere. We are producing unemployable certificate holding graduates and postgraduates, where I have DM gastroenterology students coming to me in my nursing home and telling me that we do not have exposure to ERCP, we want to work with you for some time to learn ERCP. What are you holding that certificate for? An MS surgery, if cannot perform a laparoscopic cholecystectomy and he is given a certificate of Master of Surgery, that certificate holds value in the eyes of a lay person. That certificate holds value in the eye of courts. But we know the fact that the person does not have the competence to perform a surgery independently. So something is wrong somewhere. We have been writing to National Medical Commission, and as Dr. Suresh said, they have recently come up with these. I have had discussions with Dr. Paul also on this matter. The point remains, we need to move away from the super specialty culture. We have a tendency today to divide each subject into subspecialties, sub-subspecialties, and what we are doing is creating more and more doctors who know less and less. Whereas we need doctors who know more and more. So when we start doing this, I mean, I was very strongly critical. Recently, I was with the Foxy meet, and they were discussing starting a program of DM or MCH in reproductive medicine. What is MD Gynae if it is not reproductive medicine? You are already MD Gynae. We are having a situation in PGI where when the person is in doing his post-graduation in surgery, they do not expect the person to learn surgery. That is expected to be learned when the person goes to senior residency. And when the person comes to senior residency, he is acting like a traffic policeman, where one patient comes, he says, go to being challenged in Supreme Court that live surgeries should not be performed at conferences. I have learned maximum procedures from live demonstrations in major conferences. So we need to really introspect and look what we are doing. We already have a glut of engineers in India who are unemployable. We already have a glut of dentists in India who are unemployable. Let us not start producing a glut of, और ये जो doctors का glut आएगा, ये specialties, super specialties से शुरू होगा, and then it will percolate even to MBBS. We are just rapidly increasing the number of seats and the whether by political pressure or whatever, I don't know. But curriculum तो automatically change होता रहेगा because technology इतनी बदल रही है. जो फेको पहले अवेलेबल नहीं थी, जब डॉक्टर सुरेश वगैरह ने करा है, उस समय ओपन कैटरैक्ट सर्जरी हुआ करती थी. आई थिंक
Just shifted to FICO.
it shifted overnight. The demand from the patient was such. Institutes were not doing FACO at that time when patients were demanding it outside. Am I correct? Even PGI introduced FACO much later. So curriculum has to evolve. Whether we want to or we don't want to, it will be forced on us. And change is life. You cannot say that we will remain static. What is today has to change to be a better tomorrow. Or ophthalmology, ma'am, I must say a last thing. I see the majority of your students are girls. No, this is something that is very, very serious. Why? Because हमारा social structure इस तरह का है कि हम इनको आगे बढ़ने नहीं देना चाहते. और जब हम speciality से super specialties में ले जाते हैं, this is what is happening. I was giving a talk in the Indian Society of Gastroenterology, and there were at least 300 delegates over there. And I asked them very clearly, but effectively 3% of them were females. The reason why they are not able to progress is because वो family commitments, ये हो गया, वो हो गया. Ultimately, a 747 aircraft can be flown by a 24-year-old. Average age of people permitted to fly aircrafts is 24, 25. Why are we having so much difficulty in letting technology in the hands of youngsters and train them on the maybe simulators or wet labs as
That's the way to go, because I mean you can't really hand over patient to a first year resident.
I agree.
So during first year and
Well,
second year they have to do
I
wet
would
labs.
beg to differ because it's deviating from curriculum to gender, and unfortunately, me also being a female person, and I don't think I've been unsuccessful in any way to sort of think that having more women in the field is sort of a red flag that the branch is going downhill.
Denying a fact of life in India.
Well, you
it
have a
is
very successful wife and now a very, soon to be successful daughter. So let's not bring gender into it when we are, talking on a forum where we have a lot of women as faculty, and I'm sure in other branches too. The All India Ophthalmic Society is being led by a very dynamic woman, Dr. Namrata Sharma. So we are just focusing on the curriculum aspect of it. Let's not bring gender to dilute it even further and demean the contributions that women give. Actually, we should be acknowledging the women more, because not only are they advancing in holding places of repute, they are also managing their homes.
And my point is to encourage, not to demean.
It sounded the other way, sir,
You
but
are mistaking. Somewhere you have taken it in the wrong sense.
well, it was. See, the curriculum has got nothing to do with gender.
If you extend the curriculum for 15 years for something which should be restricted to 8 or 9, the disadvantage is going to be of the female gender in our society. My point, you are missing that point. When we
That's
talk of
universal,
super
sir, because
specialties-
everywhere across the globe, women will have children, women will have a household. So that's pretty much a universal fact, and
So my point is only not extending the training for too long. What is happening in super specialties is people are losing a year or two getting post graduation, then they are losing a year or two getting super specializations. By the time they finish MCH programs, they are nearly 33, 34.
so maybe we can have a comprehensive program.
Yes, this is
So,
where I'm coming to.
Instead of 3 years, we can have 4 years of a postgraduate training, wherein we make sure that after first 2 years of initial good training of comprehensive stuff, the other 2 years are more focused into the area of interest of the candidate, and we make sure that they learn a sufficient amount of surgery so that they are equipped enough to practice in public after their 4 years of PG.
Bang on, you've got the point this time now. This is exactly my point. Once we give a certificate, they should be able to perform what is expected of them in the society.
I think I agree with Dr. Parul. I give my personal example. I have one daughter and she is doing MBBS. She is presently doing internship. What happened was, I tell you why both girls are coming in ophthalmology. What happened was, she was in first part of final prof, and the subjects were eye, ENT, community medicine, and forensic. What was?
It's like community
I-
care.
No, the new curriculum has forensic and
So she had a lot of problem in going through these subjects, especially optics part of ophthalmology. So somehow I taught her 2 or 3 chapters on optics or what, and her concepts became clear, and she became a fan of ophthalmology. I want her to take medicine, and I asked her, what do you want to take? She says ophthalmology. Now ophthalmology is a much sought after subject.
It is.
Because medical retina is so easy and such, it gives you so much success in life. And glaucoma, cataract, everything is, and technology is coming up. So girls are doing very well. And basically they are coming to this profession because in NEET PG they are scoring much higher than boys. And ophthalmology is a respected subject. That's why more girls we see in ophthalmology. So let us,
My point is different. My point is there is 55% girls who are entering in an MBBS batch. By the time you reach super specialization, this number reduces to 10% of the people doing super specialization. My point is simply by stretching the training program by so much, super specializations and specializations, and then there are times in between, we are discouraging this is where my point comes. So what she has said is absolutely right. If we can have a comprehensive, limited time frame program where we produce people who are employable immediately.
So regarding training program, as I can share my experience, because I have worked in, I did my senior residency from PGI, worked in medical college, now work in private sector. What is important in life is to become a very good, confident ophthalmologist. That is the end point,
Yes.
right? So during the PG in PGI, uh, the, we used to read all sort of books. Falling for cornea, Wills for orbital diseases, Ryan for retina, and 3 years we were reading chapters from those books. And when it came to examination, we remembered nothing. And ultimately it boiled down to Kansky. So we read Kansky in the end and somehow got through the examination. So that means in curriculum, whatsoever you, this is just to pass examination. You should know only few basic things. Now if I ask you, describe the autofluorescence. In which book, tell me in which book you are going to read about it. I'll ask you, okay, tell me the principle of optical biometer, where you are going to read it. Or show me the laser parameters, in which book, there are hardly any books available. These are available here and there. There is not one standard book. So you should, first the theory part. You should read minimum number of books where you can acquire maximum number of knowledge, so that you go through the examination comfortably without any stress. So that is one suggestion. Second is, now coming to second part, that you have to be a good ophthalmologist. So it is very, very important that every postgraduate student must try to do a senior residency or a fellowship. Some people will get it directly, immediately, they will become more comfortable. Others who do not get it, they should join whatsoever available hospital is there, or own practice, group practice, or corporate, and but they must keep trying for fellowship or senior residency down the line. So once they have done the fellowship, only then you will become confident in that particular specialty. Then nobody can stop you from becoming a good expert ophthalmologist. So these two are different things. One is curriculum. Whatsoever curriculum is provided by the authorities, by the government, colleges, institutes, you just have to take minimum material so that you are able to study, clear your exam, and focus little bit on each area. You keep reading Ryan, but ultimately you remember nothing. What is the purpose? You read Atul Verma, it is a smaller book and it has the latest.
Much more than Ryan. So you have to choose your books correctly. For reading Retina, you don't read Ryan, you read Atul Kumar. Retina by Atul Kumar. Same way, you take smaller books so that you have all the information in a limited way and you are able to clear your exams. I'll give you one example. The success is not about the curriculum or the percentage of marks. In the private sector where we all four of us worked, we started DNB program. In the DNB program, there were 4 students. One student he knew that his parent had a hospital in Roper and he would go for practice. He would come to me, he will learn Western injections, medical retina thoroughly. Then in the curriculum we had built that each DNB fellow will conduct 30 phyco surgeries. And there was a logbook. I think that is the most important part of curriculum. That if you are in an institute, there should be logbook and there should be minimum number of surgeries. So he did 30 phaco surgeries and he got a good feel of it. And after completing DNB, now he is practicing in Roper, conducting daily 8 to 10 phaco surgeries, and he is also giving Western injections. And he is doing very well. So clearing exam is a different thing. Having confidence in your work is altogether different. So for that, in nutshell, you have to do a fellowship or a senior residency. After post-graduation, you will be jack of all trades, but you have to become master of one trade.
I would like to add one thing to this, sir. A lot of it has to come from the student. You have to be proactive too. Every teacher is willing to impart whatever they learn. And I think this is a teamwork, so students and teachers together, and it's a curriculum for life. It doesn't end after senior residency or fellowship, and each of us, our patients is teaching us, each of our colleague is teaching us. You know, I saw your OT notes when I was a senior resident, and I saw a patient who was operated 7 years prior to my joining that center. And I loved the notes so much that I started writing my notes in a fashion like yours. So it's how observant you are, how proactive you are in changing your technique and learning whatever new we can. So it's a lifelong process, it has to be dynamic. And I take the point in a very good spirit that yes, it has to be abbreviated in a manner that you become fruitful as early as possible when it comes to offering your skill set to the patients. But till the time that happens, we need to understand that we have to go beyond the books. We have to learn practical measures, be it from live surgeries, from the online videos, from review articles, from standard journals, and we have to constantly scrutinize our own skill set so that we keep evolving and don't become stagnant. So having said that, we move on to the second aspect of the training. And can you move the slide? So I'm not able to move it from here. Which is the variability in the training. So there are certain centers, certain states where the government medical colleges are not really very well equipped, and the training there is very basic. They lack the basic set of imaging equipments, and they lack subspecialty clinics and training. And on the other hand, we have advanced centers which have actually some way compromised the comprehensive eye care. They are so focused on subspecialty, so you're posted in glaucoma, plasty, retina, and you are very good at that. But when you have to assimilate everything together in one patient may have glaucoma and band-shaped keratopathy and have a retinal detachment, then putting all the jigsaw puzzle pieces together becomes difficult for some students. So too basic and too advanced. Unfortunately, we are a very huge country with a lot of states and with a very variable training pattern. So definitely we need to redesign the ophthalmology residency program. I would like to have your inputs. How do you think, sir, starting from you, how do you think a correct message can be conveyed to the NMC to somehow bring everything to a middle ground that people become employable in an early fashion?
This is something we have already shared in a representation to NMC, and this has been ongoing for a number of years now. What we are doing is today, we are delivering a degree. All I have said is, in case you want to give MS ophthalmology, add theory after it. If they are not going to be surgically trained, then say this is MS surgery theory, or MS surgery history writing, or MS surgery trolley pushing. Because what they are training in, once they have a certificate to say they are master of surgery, whether it is ophthalmology or anything, I expect them to be able to give surgical services to the community which is asking for it. And mind you, the courts look at it, that certificate very importantly. It is we who know that MS surgery certificate is not carrying that much weightage within our community. Because unless and until, as he said, you do a fellowship or you do senior residency, but the point is there is a pyramid. You have so many people who are doing post-graduation, you have fewer numbers of senior residencies, you have fewer numbers of fellowships. How many MCH programs are there in ophthalmology in the country?
I think just
So when you say that everybody should be doing a super specialty, you are forgetting there is a large number of specialists who will not get an opportunity to do super specialty. And majority of them, I'll again come back to my main point, which will be women. Because for some reason, they will be shunted out of the race.
I don't like to bend when I don't agree with something.
Oh.
I think
I
the
can't
most important aspect for this thing again for training is that if you remain dependent on government, curriculum, that they should set some standards. I think the best is that somehow during post-graduation, number should be set. For phaco surgery,
Yes.
maybe 10,
Yes,
10
yes.
in number.
I agree.
For senior residency, maybe 50 in number at least. And logbook should be maintained and signed. Until unless you have a logbook and that logbook is signed, filled, entered, then until you can't have the confidence of surgery.
100%. This is the point which has to be taken.
Very
And
So,
We can't have a
institution.
PPV in MS, but we can definitely have a set.
yes, once you have the tissue field,
Yes.
you can perform other surgeries also. You must have the
Essentially,
tissue field.
it's a very mathematical model where you want to set things right and make the equations equal on both the sides when you are operating on any organ for that matter. If you have a common sense of tissue holding and how the physiology works and how anatomy has to be set in the correct fashion, I think everybody is a good surgeon. And we all know that there was a time when people who used to assist very eminent doctors, even the compounders,
Yes.
those who were labeled compounders, were even better surgeons than many students. So it's all about the skill set and the observation which the students have, but we owe it to the students to provide them with a certain fixed number of platform to.
In the surgical field, it has to be surgical training.
Yes.
They are all intelligent people. Anybody who is clearing neat and coming into post-graduation, even if you don't
But
teach
it's
theory,
it's
they will
going
they will read the
beyond
books, they will
3
know
years of
everything
MS.
about theory.
We
They have a year to.
Not 12, 30. My
Yeah.
point is there. And number two, institution to institution variability can very much be there.
True
Right?
that.
It will always be
It will
there.
always be
So
there.
we can't make it very uniform. So I want to highlight one fact that during our residency program at PGI, we had subspecialty clinics. And all of us were rotated in different clinics, maybe uveitis clinic, Professor Gupta, retina clinic, Dr. Ugra, Dr. Jagatram, everybody, Dr. Pandav, glaucoma clinic. So, and we were exposed to all surgeries, all type of surgeries. So we were as first assistant, we were seeing through the microscope. So then wet labs were not there, simulators were not there. And during my junior residency, I think I did very few surgeries. Surgical exposure was always lacking. And it's everywhere, it's not only in India. Go to West, go to any country. Surgical, we don't expect a junior resident to become a surgeon like a professor. So the idea is to expose them to everything, all type of surgeries. And if they are assisting as first assistant, you absorb so much. So when in senior residency, I started doing surgeries, I never felt that I have never done. So with time, I never did phaco in my junior residency or even senior residency. So it doesn't mean that I can't become a phaco surgeon. So now I am doing reasonably good phaco surgery. So I don't agree with Dr. Nagpal that at the end of 3 years of residency you will become best surgeon in the world. It's not possible, and it's not even the intention. How can a person become surgeon in 3 years when you are learning so much? You are learning theory part, you are seeing patient, you are learning communication skills, you are learning all subspecialty, you are getting exposed to 15 subspecialties in ophthalmology. How can you become surgeon in every area? It's not possible and it's not required also. But you have to assist. You have to look through the microscope. Even if you are assisting 100 phaco surgery, what is happening? After 10 surgery, resident feels, I may not be looking. Then this is your loss. So if you have assisted 100 surgeries and you were attentive during surgery, so whenever you start doing surgery, later on, it will be very easy. It's like walking the road. So I think we are talking of something which is not in our hand. Curriculum, change of things, NMC, will it listen to us? It will never listen to us. It will never listen to anybody. I will make anybody chairperson of that. The mindset is fixed. It will take years. And in our lifetime, I don't expect things to change so drastically. So we are asking for moon. We should not be asking for moon. We should ask for something which is practical. So we have to find practical solutions. So I fully agree with Rajiv. He has highlighted the fact that at the end of junior residency, you should be exposed to every area. You should be assisting every type of surgery. You should be able to make clinical diagnosis. You should have been exposed to your wet labs. You should have been exposed to simulators and done few surgeries independently. That's the thing we expect from a junior resident. And then during your senior residency and fellowship, it's must. How come in a surgical training at the end of junior residency you become expert surgeon? It's not possible anywhere in the world. So how come we become different from the world? It's not possible. It's not possible. We have to be realistic, and reality shows that we can train junior resident in good number of things, that is clinical diagnosis, making differential diagnosis, reaching the diagnosis, choosing right line of management, assisting surgeries, doing wet lab surgeries, doing simulator training, and doing few surgeries independently. And then during senior residency they can choose the area where they have developed interest in during their junior residency. Like in senior residency, when I worked with Professor Pandal, I started developing interest in glaucoma. So that's how when I came to medical college and there was no one in glaucoma specialty, I started glaucoma subspecialty. So this is how I now we have well developed glaucoma clinic in our hospital. So I think we have to be very realistic, and we should not be thinking and wasting time on things which are not in our hand. We should focus on things which are in our hand and where we can work. And then I think the way to go forward is what Rajiv has suggested.
So I'll give you two examples. One is CMC Ludhiana, one is CMC Bangalore. CNC Ludhiana training, I was trained in CNC Ludhiana. Professor F.C. Kristen was the chairman as well as the head of surgery. They had instituted a program where a first year resident who joined, and we used to join as house doctors, he had to be the first surgeon for all hemorrhoids. The head of department would stand on the other side of the table and assist him. The moment he moved from 6 months to 1 year, this was shifted to hernia. All general patients who were general ward patients would be operated, the first surgeon would be the resident. And as he became senior, the level of complexity of surgeries increased. They may not pass a student within 3 years. They may take 4 years, 5 years to pass. But his words I still remember. If I have given you a degree, I expect you to be capable to operate on myself. This is my training background which I am coming from, and which is why I am saying this. And this is the same procedure which is followed in CNC Bangalore. So it is not out of the world what I am talking about. And nobody needs to be trained in everything in 3 years. There is some basic things which are expected of an MS surgery. And my expectation from the teaching program is that those basic things the person should be competent in.
Partly agreed, but we have.
I think the surgeries have become very complex nowadays.
That's
So
about the equipment.
eye surgeries, I mean, it involves lot of technology. It's not like hemorrhoids or hernia or you go ahead with naked eye and without any special equipment. In ophthalmology, you have to be used to microscope, and it takes minimum 1 year to get adapted to the microscopic
The
environment.
ambidextrity,
So,
the hand-eye
so
coordination
many
takes
hand-eye
time.
coordination takes more
Supposing
than
you
6
start
months.
training at the age
So-
of 30 years, he will take 33 years to become trained. If you start at 24, he will be trained earlier. There
No,
are
no, sir,
countries
we
where-
are training our
हाँ,
resident
मतलब
whenever.
अपना वो मत है. My
Every
point
college.
I think we need to move on to the next aspect because we also have a quiz after this session.
Successful, because you won't have a job of your choice. You won't have government job. Don't have government sector. You don't have group practice. You can't start your practice, solo practice. So much money is required. So for 4-5 years, again you will have a lot of stress. So that part you must understand right now, that even after senior residency or fellowship will take some time to settle down.
But
But
eventually,
that is
if you are
okay. That is the
persistent,
system all of us have gone through. After finishing my senior residency, I was jobless for about 3 months. I went to every nook and corner in North India to find a job. Some was offering peanuts. And then finally I landed some job in Chandigarh and did some medical work for some time. Then gradually salaries came by, and then gradually after 5, 6, 7 years,
So
I came.
so you have to be persistent and.
I'm sorry, sir, I'll have to cut
No, no,
short.
please finish.
The mother-in-laws are also becoming fancy and younger, and so there is a changing value system. We have to acknowledge and strike a balance because the social media is making a huge impact in the mindset of the youngsters. So I just wanted to convey this point because sometimes in the heat of the moment, some young budding doctors, they sort of take it, they take a suggestion or a comment too personally, and they sensationalize the matter and go to social media. I'm not saying that some of them are not in the right, but having a cool mind, treating your faculty like a family needs to be done because there has been a change in our value systems, and so there has to be a common ground between old school versus Gen Z. So probably let's meet at the millennials and let's have a very cordial, proactive, a very communicative sort of a relationship so that we can thrive together and we can learn as long as possible, because it's a very long journey in relationships in this branch with each other. We look up to our seniors for their suggestions even now, and this is something which has to go on, so that mindset needs to be there. So having said that, I think I thank Professor Nagpal also for coming here and giving us very valuable comments, which definitely strike a chord in our mind that things have to change. How they will change, when they will change is something that needs to be said. Thank you, sir, and thank you, Professor Gupta and Dr. Rajiv, sir, for sitting through this and giving your suggestions and comments. Thank you once again.